So, good evening and good afternoon and good morning to Dr. Zhang. So, we are delighted to hold the second session of APASL Liver Cancer Plus Scholarship ALCAP program this evening. I'm Dr. Shuichiro Shina, the president of the 33rd annual meeting of APASL. That is APASL 2024 Kyoto. Liver cancer is predominantly hepatocellular carcinoma, is the fifth most common prevalent cancer and the second most common of cancer-related deaths in the Asian Pacific region. And in 2020, a total of 609,500 is newly diagnosed, and a total of 566,000 died from HCC in this region, which is estimated to account for the total of 72% worldwide. So today's topic is pathology of HCC. We hope that this session will deepen your understanding of the pathology of hepatocellular carcinoma. Thank you.
Thank you, Professor Sheena, and thank you all the moderators and the speakers for the day. I would like to give a message that APASL and our steering committee is committed for increasing awareness across the world, especially Asia, about liver cancer. And today we are very privileged that we have people from Indonesia, Bangladesh, from US, Japan, and of course from Vienna, from Austria, and many other colleagues across who are listening. This is the second session. We would like a feedback whether this is enjoyable or not. The format is 2 dedicated lectures followed by discussion and a clinical grand round. And today we have Professor Marcus, who is in fact an excellent clinician and teacher. So with this, I would like to pass on to Professor Rinogani, our past president of the APASL and a leader in his own right, and Professor Mamoon from Bangladesh. Professor Rinogani, please.
Dr. Gani, Professor Gani, we cannot hear you. Mute.
Dr. Gani, please unmute.
Sorry. Sorry. Yeah. Thank you for the Professor Sarin for the opportunity to moderate this session. And in this session, we have speakers from Austria. Please allow me to
First is Professor George Lau, our own Professor Lau. We would like...
Yeah. This session will be divided to 2 series, series 1 and session 1 and 2. And for the first session will be chaired by Professor George Lau. And Professor George Lau is a professor in the 5th Medical Center of Chinese General Hospital Beijing Humanity and Health Medical Group in China. So, and then for this session, I will leave to Professor George Lau to make this presentation.
First of all, I'd like to thank the moderator of these sessions, Professor Matip, and also Professor Gani for the kind introductions. And we have all heard about the introductions by Professor Shina on these very important programs activated by APASL, the ALCAP, APASL Liver Cancer Preceptorship Program, aiming that as a postgraduate learning opportunities for all the young doctors to be involved in the hepatology practice. The topics today assigned to me is when biopsy is needed for liver SOL suspected of liver cancer, that is hepatocellular carcinoma. I'm George Lau from Hong Kong, Beijing. This is my brief introductions. I've been in practice for hepatology for over 30 years. This is my disclosures of conflicts of interest. Liver biopsy is a very important procedure required for the diagnosis of various liver disease, especially for hepatocellular carcinoma. It was first initiated in 1883 in Germany by Paul Ehrlich. Since then, and until 1958, the Magani needles was introduced, and therefore the procedures was becoming more widespread in clinical use. In 1972, using the Holmes transducer at that time by Rasmussen, who first described the use of ultrasound guidance in the biopsies of hepatic metastasis. And this has led to the present modern developments of image-guided biopsy of space-occupying lesions in the liver. It is very important we have histological diagnosis of hepatocellular carcinoma so that we can classify them according to the WHO criteria: well-differentiated hepatocellular carcinoma, moderately differentiated hepatocellular carcinoma, or poorly differentiated hepatocellular carcinoma, carrying the different prognostic values and may affect our management and choice of therapy in the future. We are also able to identify the growth patterns of hepatocellular carcinomas based on a certain histological characteristic as exemplified here in this slide. Having said that, image-guided liver biopsies is increasingly being used in clinical practice. Usually it is done under the guidance of ultrasound or CT scan, where in those circumstances where the lesions cannot be identified by ultrasound, CT guidance will be required. However, to perform a liver biopsy for a space-occupying lesion suspected to be hepatocellular carcinomas carries a certain risk, such as bleeding and the needle tract implantations. And also we need to consider the liver functions of those patients when they undergo a liver biopsy, especially for those patients with poor liver functions or end-stage liver cirrhosis, the risk of bleedings will be increased. And it is very important that when we do a liver biopsy, we get the site correctly identified by the imaging. And it is not an easy task. And we have seen in real life, in many circumstances, that the right site of the biopsies is being missed, and we cannot get the right tissues. Concerning about the complications of hepatocellular carcinoma biopsies from space-occupying lesions in the livers, it includes bleedings, as shown in these tables, and also seeding problems, up to 5.1% for seedings and up to 7.9% for bleeding. This is a collection of data published in the literature for over 20 years. At this point, I would like to share with all of you a very interesting case I have encountered recently to illustrate how we should decide whether the patient should have the image-guided liver biopsy for a space-occupied lesion when we suspect they suffered from hepatocellular carcinoma. This patient was seen by myself at the first time in 2016, August 26. At that time, he was 38 years old. He was a male subject with a beautiful family, with young children. He was a non-smoker and a non-drinker. He was surface antigen negative, anti-HCV antibody negative, with normal liver functions, and alpha-fetoprotein was normal, together with also other tumor markers such as CEA and CA19.9. He was referred to me because incidentally, the ultrasound findings shows a 3.6 times 2.2 centimeter space-occupied lesions, as shown here in the figures, in the anterior parts of the subcapsular regions of the right part of the liver. CT scan was done at that time, that was in 2016, more than 5 years ago, which shows a 3.7 times 2.8 times 3 centimeter arterial enhancing lesions at hepatic segment 4 and 5 anterior subcapsular regions. There appears to be a central artery. There is presence of portovenous and delayed scan washout, and hepatocellular carcinomas cannot be excluded. Now, at that time, we decided to do a PET-CT scan with C11 acetate by our colleagues in Hong Kong Sanatorium Hospital. This is the result. As you see here, C11 acetate, the SUV max is 8.0. The differential possibilities included well-differentiated hepatocellular carcinomas or focal nodular hyperplasia. This is a difficult situation because the patient has no risk of hepatocellular carcinomas in terms of chronic viral hepatitis B, chronic hepatitis C. He is a non-drinker. There is no fatty liver, no steatosis, and there is a space-occupied lesions. At that time, with joint decisions with our surgeons, with our radiologists, and myself, we think that the patient has focal nodular hyperplasia because of the constellations of findings in terms of liver biochemistries, the tumor markers, and also the risk factors, and also the imaging findings. Therefore, the patient was followed up. That was what we have decided to do at that time. Considering the imaging characteristics and the normal alpha-fetoprotein levels, we follow up the patients at my center by myself every 3 months with ultrasound and alpha-fetoprotein. The decision was made in 2016. That is more than 5 years ago. During the follow-up period from August 2016 to March 2021, there is no increase in the space-occupying lesions. It remains at a similar size by ultrasound, 3.6 centimeters times 2.1 centimeters, and alpha-fetoproteins remains normal. In 2021, June, a repeat ultrasound at his routine follow-up. He is a very compliant patient with beautiful family supported by the wife. The ultrasound by myself shows that the space-occupying lesions actually has a slight increase in size. It's 4.7 times 2.8 centimeters. Taking into consideration, it's almost close to a 5 years follow-up. The alpha-fetoprotein is still normal. So what have we done? Well, it's worrying. The lesions is getting increased in size by ultrasound monitoring 5 years down the road. So we have a PET scan performed on these patients again with the C11 and also the FDG by our radiologist in the private hospital, which shows that there is an increase in C11 acetate, a more than 53.8% increase. Very suggestive of hepatocellular carcinoma this time. Well, at that time, we decided to have a tissue biopsy. Ultrasound-guided biopsy was done in July 2021. on the lesions, which is at that time was shown to be 6.1 times 2.2 times 5.3 centimeter with 4 passes made. So we have adequate tissues. Pathological diagnosis at that time shows hepatocellular adenoma because there is abundant nuclear beta-catenin positivities being shown. Wow, this is a benign tumor, but increase in size. This is where we worry. Our pathologist does not think that the patients have hepatocellular carcinoma. So what did we do next? And what will you do? Maybe this will be brought into discussions later on. But at that time, I make the joint decisions with our surgeons, Professor S.T. Fan and also Professor S.C. Chan. In view of the increase in size of the space-occupying lesions over 3 months, we have repeated ultrasound. We are still worried about false negative biopsies. And therefore, after lengthy discussions with the families and with the patients, we decided to go ahead and have hepatic resections. And that was done in August 2021. The pathological diagnosis, which comes back at that time, is well-differentiated hepatocellular carcinoma, nuclear beta-catenin negative, as shown here in the slides. The patient is still being followed up in my center, and now it's 2023, coming into May. No new lesions is being seen, and the patient is in a healthy state, with no suggestions of any recurrence in the liver. So what have we learned from this case? This is not the only case with similar pattern we have observed. A pathological diagnosis based on liver lesions biopsy under imaging can carry a risk of false negative, either because of the insufficient sampling or inaccurate sampling locations. And the negative results from liver biopsy did not exclude the possibility of hepatocellular carcinomas, as shown in our case. So how about the literature? When we review the literatures with all the publications since 1996, and up to the 2004, you can see here, though the positive predictive values is close to 100%, negative predictive values varies from 13 to 75%. And therefore, this is one of those cases where the biopsies shows a negative result of hepatocellular carcinoma. But indeed, the patients have hepatocellular carcinomas by image-guided liver biopsy. In my current practice, this is what I'm doing in my center with my colleagues at the Humanity and Health Medical Center. We take care of around 500 to 1,000 chronic hepatitis B patients every 6 months. And you can see here, ultrasound was usually performed to detect a space-occupying lesions, and that's the reason why they refer to us. We will then have a CT scan for those patients with space-occupying lesions. And if they show the typical imaging patterns and increasing alpha-fetoprotein with a solitary lesions, as shown here on the CT scans, with arterial phase enhancement, portovenous phase washout, and the delayed phase continuous washout, then we'll resect the tumor, resect the lesions with no needle biopsy or image-guided liver biopsy. For those patients who has unresectable HCC, multifocals, or already spread, biopsies will be performed by imaging guidance, because we use this for either for participation in clinical trials and at this moment to guide the systemic therapy. This is therefore my practice. Ultrasound, space-occupying lesions, we'll do a CT or MRI. If it is an inconclusive imaging pattern plus alpha-fetoprotein normal, we'll follow up the patient regularly to monitor the size and whether there is any change in alpha-fetoprotein level. And for those with a space-occupying lesions growing in size or changing pattern, then we would perform a resection for solitary lesions. We do not advocates liver biopsy for this type of lesions. 2023 and beyond for HCC management, we are coming to a phase when we have new systemic therapy made available, either as TKIs or immune checkpoint inhibitors. And to this end, we have various TKIs made available for unresectable HCC, as being shown here, supported by the large phase 3 studies with RESOURCE, Celestial, and RICH2 studies, supporting the use of regorafenib, carbo, and remu for those patients who has been treated with sorafenib. And recently, new immune checkpoint therapies is made available for unresectable HCC in terms of the combinations of anti-CTLA-4 and anti-PD-1 therapies on liver cancer. This is supported by the recent publications in the phase 3 Himalaya studies, which myself is one of the first author for unresectable HCC. And the additions of this form of new therapy for unresectable HCCs using immune checkpoint inhibitors or anti-VEGF therapy or the TKI, we need more information on the histologies to guide our therapies so that we need to know, we will be allowed to know which patients should be treated with what type of therapy. Therefore, biopsy for space-occupying lesions, even if it is a multifocal hepatocellular carcinoma, not resectable, then we need to do a histology for, first of all, confirmations, and secondly, we will be able to guide our systemic therapy based on the genomic signatures, including MSI, tumor mutation burden, PD-L1 expressions, and in the futures, I do believe that we will have more advancements on the understandings of how to use systemic therapy based on the tumor microenvironment and with the studies done by RNA sequence-based analysis or mass cytometry-based analysis, that is the CyTOF. Indeed, the immune classifications of HCC has been suggested as a basis of the response to different forms of systemic therapy. This is related partly to the etiology of the hepatocellular carcinomas, such as hepatitis B or hepatitis C, versus those which is non-viral hepatitis related. But I think it's very important for us to know the genetic signature of those patients and also the tumor mutation burdens and the likelihood of all the other markers which will guide our therapies in the future for the treatments of hepatocellular carcinoma. Therefore, in summary, in our current practice, liver biopsy based on with the guidance of imaging for solitary lesions, we usually will not perform such procedure because we will simply go and resect the solitary lesions. And in the future, liver biopsy with image guidance will be of great importance to guide the systemic therapy for hepatocellular carcinoma. Last but not least, I would like to thank my colleagues at the Humanity and Health Clinical Trial Center, which make the success of our contributions in the Himalaya studies and bring a new form of immune checkpoint inhibitor therapies in terms of combinations for our patients who suffer from hepatocellular carcinoma. Thank you very much.
Thank you, Prof. George Lau, for the very informative presentation. I'm with Professor Ma'mun Al-Mahtab, and I will hand over this session to Professor Ma'mun Al-Mahtab for to lead the session. Please, Professor Mahtab. Professor Ma'mun Al-Mahtab, are you there? Oh, okay, maybe. Yeah, we will continue. Okay, we will continue to the second speaker, Professor Susan Zhang. He's from the Yale School of Medicine, USA, with the title of Interpretation of HCC biopsy for Diagnosis and Personalized Therapy. Professor Zhang, please proceed.
Can you see my screen?
Yes, yes, yes.
Okay, great. Yeah, thanks for Dr. Shena and Dr. Sarin for the opening comment. And also thanks for Dr. Gani for your kind introduction. And also thanks for the APASL for the invitation to be here. So it's my great pleasure, as a pathologist to talk in front of all the audience here, how a pathologist we diagnose hepatocellular carcinoma and what kind of challenges we have, and how about our diagnosis affects for the patient management. So liver metastasis remains the most common liver lesion in the liver, but that varies depending on the patient clinical information. For example, the status of the liver and also the patient age. If the liver is cirrhotic, metastasis is uncommon. The most common ones will be hepatocellular carcinoma or cholangiocarcinoma. And if the patient without liver cirrhosis and less than 50 years old, the metastasis and other tumors are uncommon. The most common ones, most likely they are benign tumors, for example, hepatocellular adenoma or focal nodular hyperplasia. If the patient is more than 50 years old in the liver without cirrhosis, metastasis is the most common one, and followed by hepatocellular carcinoma, cholangiocarcinoma. We also can see benign lesions such as focal nodular hyperplasia or hepatocellular adenoma. So when we talk about hepatocellular carcinoma, it not always means it is only one cancer. It is a heterogeneous group. Etiologically, it's different. And clinically, they are different. Molecularly, they are different. As a pathologist, we can see the pathology also different based on tumor by tumor. So here is our study. You can see the HCC generally they arise in the liver with cirrhosis, just like this panel. But sometimes we do see a lot of HCCs. They arise in the liver without the cirrhosis. And the etiology can be different based on the region, based on the countries. So in US and the European countries and Japan, the most common etiology is HCV. But in Asian countries, for example, in China, and the most common etiology is HBV infection. As the HBV vaccine use and also the treatment for HCV, so HCC we can see more and more arising in the background of non-alcoholic liver disease. So based on the morphology, when we have a biopsy, for example, Dr. Lau, he gave a talk, when we receive the biopsy from the clinicians, what we need to see. Now, generally for the hepatocellular carcinoma, they have 4 growth patterns. One is called the trabecular. You can see the tumor cells form this kind of trabeculae. Sometimes they form this kind of very thick trabeculae. For example, you can see here, this one trabeculae, and then the more than 10 cell layers in the same trabeculae. We call this macrotrabecular growth pattern. Sometimes hepatocellular carcinoma can have this kind of glandular pattern. We call this pseudoglandular or acinar pattern. If you do not see any of these patterns, we call this solid or compact pattern. But remember, not every single tumor, they have similar pattern. Most of the tumors, they have this kind of mixed growth patterns. Even in the same growth pattern, they also can have different morphologies. For example, the pseudoglandular or acinar pattern, you can see this one forms some trabecular pattern, but in the lumen, you can see the pseudo-acinar patterns also. And sometimes this pseudoglandular pattern, the glands can be so dilated. You can see this one dilated. They mimic adenocarcinoma. For example, maybe metastatic adenocarcinoma, maybe cholangiocarcinoma. So besides the conventional variant of hepatocellular carcinoma, they are also with a lot of subtypes of hepatocellular carcinoma. For example, clear cell, macrotrabecular massive, squamous, neutrophil rich, lymphocyte rich. You can see different subtypes. They have different clinical correlates. They have different prognosis. They have different morphologies. They have different molecular pathways. For example, here I give you a few examples of the subtypes. In the left upper panel, you can see this hepatocellular carcinoma. They have very clear cytoplasm, really mimics renal cell carcinoma clear cell type. So this is a clear cell subtype of hepatocellular carcinoma. You can see this the middle upper panel. The tumor cells contains a lot of fat droplet. You also can see ballooning degeneration. You also can see malignant bodies. They really mimic ASH or NASH. And then in the right upper panel, you can see these tumors. In the stroma, you can see this kind of lamellated stroma. We call it fibrolamellar carcinoma. And then most of the HCCs, they are hypercellular without fibrosis in the stroma. But this one you can see, we see a lot of fibrosis in the tumor. They dissect, the tumor cells to form this kind of cords. So this is the squamous variant of hepatocellular carcinoma. And then this tumor, you can see a lot of dark blue cells. They're all lymphocytes. So this one with a lot of intratumoral lymphocytes, we call this lymphocyte-rich hepatocellular carcinoma. Generally, the tumor, this patient, they have better prognosis. And this HCC, they have a lot of intratumoral neutrophils. We call this neutrophil-rich hepatocellular carcinoma. Generally, the patient with this subtype will have a poor prognosis. So in the 2019 WHO, a new subtype was included. I showed you the histology pattern before, this macrotrabecular pattern. You can see the cords more than 10 cell layers. If the entire tumor, and then this macrotrabecular pattern accounts more than 50%, we call this macrotrabecular massive carcinoma. So based on the morphology and the subtypes, sometimes we can predict the patient prognosis. For example, in our study, we can find here, so if the tumor HCC with a solid growth pattern or macrotrabecular pattern, or in the subtype of macrotrabecular massive subtype, they have a higher risk for extrahepatic metastasis. So since I mentioned for the subtypes, I give you a few examples to see how we pathologists make a diagnosis. So first example here is a 57-year-old man with a history of hepatitis B and presented with abdominal pain and ultrasound identified a 14-centimeter liver mass. You can see this mass, this biopsy showed multiple fragments of tumor. And if you go to higher power, you can see the tumor cells form this of thick trabeculae. And then even higher power, you can see thick trabeculae, more than 10 cell layers. And in the trabeculae, you can see necrosis. And some tumor cells with very large nuclei. We call this anaplastic nuclei. And then these tumor cells are particle for arginase and HyperI. So arginase and HyperI, they are all hepatocellular markers. So based on this pattern and then immunostains, we call this is a macrotrabecular massive subtype hepatocellular carcinoma. Now this tumor get resected. You can see this main tumor here, and then this the capsule, but you can see this a lot of vascular invasion here. So macrotrabecular massive carcinoma, they often with high risk for vascular invasion. So here is our study. Now we compared for the conventional hepatocellular carcinoma to the macrotrabecular massive carcinoma. You can see these tumors generally with a larger size, and then they often arise in the liver without the cirrhosis. And then the etiology more commonly seen in patients with hepatitis B. And then these tumors often in the later stage, and also higher tumor grade. They often show the anaplastic tumor cells. They often with macrovascular invasion. And also if the AFP level is often very high. If this kind of patient received tumor resection or liver transplant, they have higher risk for recurrence, and also they have poor prognosis for the survival. So let's give you another example for the subtype. This 52-year-old man with a large liver mass. You can see this core biopsy. If you go to higher power, you can see the tumor cells with clear cytoplasm. And we did the PS stain and the PSD stain and confirmed the clear cells, they are glycogen. And then these tumor cells are positive for HyperI and positive for polyclonal CEA with a canalicular pattern. and confirmed this is a clear cell subtype, hepatocellular carcinoma. But you remember in the liver, we have a lot of tumor cells. They can be similar morphology with clear cytoplasm. I mentioned before for the renal cell carcinoma clear cell type, they can have similar morphology. Even sometimes primary liver tumor, they also can have similar morphology. For example, this patient with liver mass get a biopsy. You can see the background liver biopsy, this hepatocytes are normal. And then the tumor cells with very clear cytoplasm, almost similar to the last one. But this tumor positive for CK19, positive for CK7, negative for hepatocellular markers, HyPER1 and arginase. And this tumor positive for albumin by in situ hepatization. So based on this immunoprofile, we call this is a clear cell type intrahepatic cholangiocarcinoma. So this is a third example I can give you. This is a young patient, 28-year-old man, old woman, and with a left liver lobar mass, and the MRI showed this tumor. And then the imaging study based on the morphology, they suspect this tumor either focal nodule hyperplasia, or either hepatic adenoma, or either hemangioma. So we received this liver biopsy. You can see this background liver. This is a portal tract. This is a portal tract. This is portal tract. This is another portal tract. So that means this is a non-cirrhotic liver. You also can see in this portal tract, you can see the hepatic vein with vascular invasion. This portal vein with vascular invasion here already. And the tumor cells form this kind of trabecular pattern. If you go to higher power, we can see the tumor cells with pink cytoplasm with prominent nucleoli. You can see the nucleoli with prominent nucleoli. And then we can see the unpaired vessels. Especially in the stroma, we can see the fibrosis. They form this kind of pink fibrolamellar pattern, the lamellated pattern. So this is the fibrolamellar hepatocellular carcinoma. Generally for the fibrolamellar hepatocellular carcinoma, more commonly seen in younger patient, and the liver is non-cirrhotic, and the patient without the increase of AFP levels. So grossly and radiologically, you often see a central scar. So when you see a central scar in a young patient, we always think about focal nodule hyperplasia. But remember, fibrolamellar hepatocellular carcinoma imaging study also can show a central scar. And this tumor also positive for hepatocellular markers, for example, arginase and HyPER1. But specifically, they also positive for CK7 and CD68. In the recent years, the molecular study identified this mutation. For example, they call the Parker CA and the DAGB1. It occurs in almost 80 to 100% of fibrolamellar hepatocellular carcinomas. So if you have this technology in your lab, you can do the study. You can identify this probe here, the brick, to identify this fibrolamellar carcinoma. But if you do not have this one, you can do CK7, CD68, and then young patient confirm this is fibrolamellar carcinoma. So when we see these kind of morphologies, and also patient with the risk for developing hepatocellular carcinoma, it does not always mean the tumor is hepatocellular carcinoma. For example, there is a 62-year-old man with history of hepatitis C and a larger liver mass lesion. So get a biopsy here. So if we go to higher power, we do see the tumor cells form this kind of trabecular pattern. And then the nucleus size are enlarged. But we do see something different from regular hepatocellular carcinoma. We do see this kind of fat droplet. But this is not regular fat in the hepatocytes or in the tumor cells. So it looks like this is not HCC, but this one was called HCC in another institution. When we saw this case and the patient come here for further treatment, we saw this may not be HCC. We did a marker and the MEL-A positive and the CK and smooth muscle actin positive, but HyPER1 and arginase all negative, and confirmed this is epithelioid angiomyolipoma. Is not HCC. So based on this morphology that I showed you and the subtypes that I showed you, so the tumor cells in the liver, they can have similar morphologies as hepatocellular carcinoma. For example, this upper panel, this clear cell hepatocellular carcinoma. So renal cell carcinoma clear cell type with liver metastasis, adrenal cortical carcinoma with liver metastasis, even leiomyosarcoma, with liver metastasis, they can have similar morphology with clear cytoplasm. When we have the trabecular pattern, sometimes the marked trabecular pattern, it does not always mean hepatocellular carcinoma either. For example, renal cell carcinoma, endocrine tumor with liver metastasis, they also can show this kind of trabecular pattern. I showed you one case before for the angiomyolipoma. They also can have this kind of trajectory pattern, can mimic hepatocellular carcinoma. So generally, we do not need any immunomarkers to diagnose hepatocellular carcinoma. But in these situations, we do need markers to confirm the diagnosis. So which kind of markers as a pathologist we often use? Generally, when we diagnose hepatocellular carcinoma, we use two kinds of markers. One is to use to differentiate the tumor is hepatocellular origin. Another one is to distinguish benign and malignant tumors. For example, for the hepatocellular differentiate markers, generally we use these three markers: HEPR1, arginase, and albumin-ish in situ hybridization. For the malignant markers, we use glypican-3, alpha-fetoprotein, and glutamine synthetase and CD34. And some labs, they use reticulin stem. I can show some examples here. So based on the hepatocellular differentiation markers, the most common three ones we use is arginase, HEPR1, and albumin-ish. And for the albumin-ish and more labs, they started to use this one. So generally for the arginase, they have a higher sensitivity for the poorly differentiated higher grade hepatocellular carcinoma compared to HEPR1. But albumin-ish is the most sensitive marker so far to diagnose hepatocellular carcinoma. You can see the sensitivity around 99%. But this marker cannot differentiate from HCC and cholangiocarcinoma. You can see here, there's a moderately differentiated hepatocellular carcinoma, the positive for albumin-ish. There's a poorly differentiated hepatocellular carcinoma. You cannot see any pattern of the hepatocellular carcinoma for this one. It's poorly differentiated, but positive for albumin-ish confirms it's hepatocellular carcinoma. I mentioned before for the albumin-ish also can be positive for intrahepatic cholangiocarcinoma. You can see this intrahepatic cholangiocarcinoma is positive. So fortunately, for the perihilar cholangiocarcinoma or distal bile duct cholangiocarcinoma or metastases from other organs, generally they are negative for albumin-ish. So that's why we can use albumin-ish to diagnose this intrahepatic origin tumor. It's not a metastasis. So for the malignant markers, I mentioned before the glypican-3 generally, they are positive in fetal liver and placenta. Around 50 to some labs, around 80% can be positive for HCC, is better for the poorly differentiated hepatocellular carcinomas. Generally, they are negative for benign lesions in the liver. But remember, similar as HEPR1, this positive does not always mean hepatocellular carcinoma. So many other tumors also can be positive for glypican-3. So we need to combine with other markers. Also for glypican-3 positivity, generally for HCC, they have poor prognosis. So you will know sometimes some labs, they use the anti-glypican-3 monoclonal antibody to treat hepatocellular carcinoma. For that carcinomas, they should be positive for glypican-3. So we can do these things to confirm this HCC with glypican-3 expression. You can use glypican-3 antibody treat for cholangiocarcinoma. And the CD34, in some labs, they often use CD34 to diagnose for hepatocellular carcinoma. So the reason is in the normal liver, only the portal tract vasculature endothelial cells and the periportal, periseptal, sinusoidal endothelial cells are positive for CD34. In the zone 2 and the zone 3 hepatocytes and the sinusoidal endothelial cells, generally they are negative. But when it becomes to HCC, all the sinusoidal cells, they are positive for CD34. So what's the reason? Generally the normal liver will have dual blood supply, hepatic artery and the portal vein. But when the tumor develops, the tumor only has blood supply from hepatic artery. So when the blood supply changes, the endothelial cell phenotype will also change. That's why it will become to CD34 positive. That's also the reason for clinically we treat HCC with TACE, transarterial embolization, because the tumor only with blood supply from hepatic artery. But remember also with some pitfalls, sometimes for hepatocellular adenoma, focal hyplasia, even for the thoracic nodules, they also can be patchy, strong diffuse positive because the blood supply changes. They also can cause phenotype change. So this is a pitfall. So I mentioned for alpha-fetoprotein can be a malignant marker, but generally in the labs, we do not use this one because the sensitivity is very low, around only about 30 to 40% HCCs, they are positive for AFP. So any other better ways to confirm this malignancy? So we did a study for alpha-fetoprotein in situ hybridization compared to alpha-fetoprotein immunohistochemistry. We can see the in situ hybridization, with higher sensitivity compared to immunohistochemistry. And also it's very specific for malignancy. You can see all the other benign liver lesions, even intrahepatic cholangiocarcinoma, they're all negative for alpha-fetoprotein in situ hepatization. So we can use this one to confirm definitely this malignancy and its hepatocellular origin. For example, here, this 62-year-old man with 5 centimeter liver mass. You can see this biopsy definitely is a poorly differentiated carcinoma, and this is a normal bile duct here. And this tumor negative for hyper 1. Generally, hepatocellular carcinoma, they are positive for hyper 1. And this tumor also positive for CK19 and marker 31. So we use CK19 and marker 31 to diagnose adult carcinoma, intrahepatic cholangiocarcinoma. So based on these 3 markers, we think maybe this is a cholangiocarcinoma. And also, I mentioned before, for the albumin-ish, it's also positive, but this one cannot differentiate HCC and cholangiocarcinoma. And then we further did another marker for alpha-fetoprotein in situ hepatization, and it's strong diffuse positive, confirmed this is a poorly differentiated hepatocellular carcinoma. So other markers generally in the lab we do not use, but sometimes we do use. So I mentioned before for marker 31, generally negative for HCC, but remember, if you are a pathologist, if you do marker 31, can be 8 to 10% be positive. And CK19 is a very good marker for cholangiocarcinoma. But it also can be positive in hepatocellular carcinoma, can be 10 to 15%. Now, generally, when you have CK19 positive in hepatocellular carcinoma, it always means the tumor is more aggressive, and that the tumor may have higher risk for microvascular elevation. If you get a resection, if you get a transplant, the patient may have a higher risk for recurrence and poor survival. For example, this is a poor different carcinoma. This patient with hep C get liver biopsy. You can see the tumor is poor differentiated, and the hyper positive and arginase positive confirmed this hepatocellular carcinoma. But this tumor CK19 positive. So this is a poor differentiated hepatocellular carcinoma with CK19 expression. So this one, CK19 positive in the resected tumors, you can see when they are positive, they have overall survival is worse, and the disease-free survival is worse. So in the patient with liver transplant, you can see they also with poor survival and higher risk for recurrence. So CK19 is a good marker to predict outcome in hepatocellular carcinoma. So as Dr. Law also mentioned, the tumors, they can be classified into different molecular pathways and different groups. In the recent years, you can see more and more classifications based on the molecular pathways. They can be divided into proliferative tumors and non-proliferative tumors. In these 2 categories, you also can see some studies that showed that maybe it belong to G1 to G6 categories, all divided into S2, S1, S3, or at cluster 1, class 3, cluster, class 2. So different classifications, they overlap a lot. For example, for the G3, this group, they often in the proliferative group. They often the morphology as a macrotrabecular massive hepatocellular carcinoma. They often with p53 mutation. In this category, the non-proliferative ones, you can see they have often with the CTNB1 or beta-catenin mutation. And then they can be in the we can use beta-catenin stain to confirm this mutation. So as a pathologist, we can, based on the morphology, combine with this kind of molecular changes. Different from cholangiocarcinoma, so far we do not have a good target therapy yet for hepatocellular carcinoma. So the tumor cells in the lumen, for HCC, they often have some intratumoral lymphocytic infiltration. For example, this one without the intratumoral lymphocytic infiltration. This one with intermediate amount of lymphocytic infiltration. And these 4 tumors, they have a lot of intratumoral lymphocytic infiltration. So as a pathologist, we can recognize this. We can report this. Now, based on the morphology, if we see more intratumoral lymphocytic infiltration, generally the patient with better prognosis. You can see this panel here. And Dr. Law also mentioned for the classification based on the immune score. So HCC can be divided into immune class, immune intermediate, and immune poor, or exhausted category. For the immune high grade, generally they are more sensitive for the treatment with the immune therapy for the anti-PD-1 and anti-PD-L1. For the immune exclusion group, generally they have the CTNB1 beta-catenin mutation, and then they are resistant for the immune therapy treatment. For example, you can see this one CTNB mutation without and with mutation. And then this one is resistant for the immunotherapy. So before you treat the patient with immunotherapy, it's better to have the immunostain for the beta-catenin. If it's a beta-catenin mutated HCC, it's better not to treat the patient with immunotherapy. And now continue with the immunotherapy. Not every single patient they have a response. I mentioned for the beta-catenin mutation. Also, the background liver is also important. For example, with the patient with a NASH and the patient with HCC, and the patient with HCC in the background of NASH, generally they have no response or poor response for the immunotherapy. So that also suggests, as a clinician, when we have a biopsy, it's better to have a background liver biopsy. Since we mentioned for the background liver biopsy, I will continue with this case to show you how important for the background liver biopsy. So this is an 83-year-old man with a personal history, the family history, liver disease. It's unclear what kind of liver disease. And the patient with a 1.5 centimeter liver mass, we got this liver biopsy. You can see this liver here, this pod tract, this pod tract. It's non-cirrhotic liver. And then this liver here, and then this is the lesional tissue. Even in the low power, you can see the hepatocyte here with brown color. And we saw these irons. So we did the iron stain. You can see all the hepatocytes are positive for iron stain. And then the lesional tissue here, they are negative for iron. If you go to higher power, you can see this normal background liver. You can see the with brown color, this positive for iron stain. And then the tumor cells are negative. So remember that when you see these ones, always think about maybe the patient with hemochromatosis. So when the hemochromatosis in this patient, they can develop dysplastic nodule and HCC. When it becomes to dysplastic nodule HCC, generally they are negative for iron stain, only the background liver positive. And this patient confirmed with the genetic study based on this biopsy and our suggestion, confirmed this HFE C282Y mutation. I remember this patient is 83 years old and the liver is non-cirrhotic, but developed HCC. Since this patient, he was a regular blood donor for more than 20 years. So the donate blood slowed the patient progression for cirrhosis and slowed the development for hepatocellular carcinoma. And the background liver biopsy is very important. So let's summarize what my talk today. So when we, as a pathologist, to diagnose hepatocellular carcinoma, we need to know the basic clinical information. For example, the patient age, the gender, and the background liver disease, and then if the liver is cirrhotic or non-cirrhotic. And also remember, hepatocellular carcinoma, they can have different morphologies and different subtypes. And also we have a lot of tumors in the liver, they have similar morphology as hepatocellular carcinoma. And that's why we need to do ancillary markers to confirm the diagnosis. And also the biopsy from both background liver and the lesion tissue can provide essential information for the diagnosis of hepatocellular carcinoma, also can help us to personalize for the patient therapy. Yeah, thank you for your attention.
Yeah, thank you, Professor Zhang, for comprehensive review on the pathology of hepatocellular carcinoma. We will now come to a grand round with case vignettes, and it will be led by Professor Markus Radosavljevic. I'm very sorry for the pronunciation. From the Department of Internal Medicine and Gastroenterology, Clinicum Klagenfurt.
Excuse me, sir. Here is a message from Professor Masao Omata. May we send that right now, sir? Sorry to disturb you.
Oh, okay. No
Could
problem.
you hear that?
No problem. Yes,
Hello,
please.
everybody. This is Dr. Omata. I'm very sorry I could not attend your meeting, but I overheard the term fibrolamellar carcinoma. I was one of the first co-authors of the original paper published many years ago with Hugh Edmondson and Bob Peters. So I was very much interested to listen to your talk, lecture, wonderful talk. But unfortunately, I was stuck with other meetings. So could you send my convey and then congratulations about your talk? Thank you very much, Omata. See you soon.
Thank you, sir. That's all, sir.
Can
Oh,
Can we ask Professor Ghani one or two questions to Professor Zhang?
Yes, yes, please. Professor Sarin, do you have any questions from it?
Yes, I wanted to know his opinion on a steatotic HCC and also a scarce variety of HCC. So you do a biopsy and you have a lot of fat. That may be a patient of NASH, may not be a patient of NASH. So if we have a lot of fat in a liver biopsy, you think it can respond to therapies like immune checkpoint inhibitors? And second is scarce, extremely fibrotic liver. Thank you.
Okay, first, answer your first question for the steatotic variant of hepatocellular carcinoma. So this variant hepatocellular carcinoma can arise in the liver in the background with or without NASH. So can be seen in the patient with NASH in the background. Can be seen in patient with alcoholic alcoholic liver disease. Also can be seen in patient with Hep B, Hep C. So when you see the steatotic hepatic variant HCC, does not always mean the patient with NASH. So there's no correlation. So that's the first answer. And also, so far the study only compared for the background liver, the patient with NASH or non-NASH patient. So only the NASH patient, they have poor response for the immune therapy. So even though the tumor is with fat in the tumor, and the patient with background liver disease is HCV or HBV, they're still with a better prognosis for the response for the immune therapy. So that first question. And the second question for the scarce variant hepatocellular carcinoma. As you said, there's a very fibrotic background in the tumor, different from other HCCs, because other HCC, you can see a lot of tumor cells. This one with a lot of fibrosis. Yeah, for this one, this also for us is always challenging to make a diagnosis because this tumor sometimes can mimic intrahepatic cholangiocarcinoma. And also for imaging study, so they also mimic cholangiocarcinoma. So we do markers. For example, HEPR1, arginase, they're always positive. And remember, this tumor also positive for CK7, CK19. So they are marker for cholangiocarcinoma. So when you see CK7 positive, do not only go to cholangiocarcinoma. Think about maybe this scarce variant for the hepatocellular carcinoma. So you need to do markers for HEPR1 and arginase to confirm the diagnosis.
Excellent talk. Thank you very much. Over to Dr. Ghani and Dr. Mamoon.
So there are two questions for Dr. Zhang. Can you answer now?
Yes, I'm here.
Yes. My colleague, I have informed that my colleague already in this session, Professor Mamoon Al-Mahtab. Would you please proceed to the grand round of the question and answer?
Ghani. We are now towards the end of the session. The last part of today's session is grand round, and the grand round will be presented from Austria by Professor Markus Peck Radoslavik. So I have the honor to invite Professor Markus Peck Radoslavik to please present the grand round. Thank you.
Yeah, so hello everybody, Markus Peck here. My presentation, my short case is pre-recorded, so the case will be, I think, played as a recorded case. And after that, we will discuss topics as they arise. Thank you very much for APASL for having us, or me here, to give you at least one case that's a more European case. Hello, everybody. My name is Markus Peck, and I'm from Austria. And I'm very happy that I was invited by APASL to give you this short case for the preceptorship, APASL liver cancer preceptorship program on how do I diagnose HCC role of pathology. Now, you have already heard the talks of the radiologist and the pathologist, and so this is just a small case for discussion. Here are some of my disclosures. So this is a case that we were taking care of in southern Austria, in Klagenfurt. You see the patient profile was a 66-year-old male, a Caucasian. He had 95 kilograms of body weight and was 189 centimeters tall, with no apparent symptoms. But he did have a remarkable past medical history with coronary heart disease that was stable, but still there. He had COPD grade 2 due to previous smoking history. He also had a pathologic glucose tolerance. He had arterial hypertension, polyneuropathy, probably due to his pathologic glucose tolerance, but we don't really know exactly. And then in the more distant past, he had some meniscus surgery on his left knee. Now, despite having no symptoms, he did undergo an ultrasound, not for screening purposes, just for some other purposes. And that's where a lesion was detected in his liver. So his echo performance status was 0, so he was in good condition. But if this would be an HCC, it would be BCLC stage C. He would be a non-cirrhotic patient, and the tumor locations were 2 tumor nodules in the liver, plus pulmonary lesions in both lobes. He had more right than left. And the major lesions were in the liver. In segment 2-3, there was a 11 centimeter by 10 centimeter large lesion, and there was a smaller lesion in segment 6, 2.4 times 2 centimeters in diameter, plus the lesions in the lungs were smaller with a maximum diameter of 9 millimeters. He had no apparent macrovascular invasion, but he did have extrahepatic spread. For that reason, he would have been BCLC stage C. He had normal AFP. His albumin was reduced, probably because he had not eaten too much. His bilirubin was slightly elevated, but this was most likely due to Magen-Gracht's disease, and his AST was 50, his ALT 24. Now here you do see his baseline MR imaging of the liver. You see the liver is non-cirrhotic here, but you do see the large nodule in the left liver lobe. It's inhomogeneous on arterial phase imaging here, but you do see there's uptake of contrast agent, plus he does have a clearly hypervascular lesion in segment 6 that's smaller. And then when we move on to the venous phase, you do see there's some necrotic areas here as well. There's some washout in the big lesion, and there's definitely washout in the smaller lesion in segment 6. So if this would be a cirrhotic liver, we would have no doubts, but this is not a cirrhotic liver. And then here you do see his lungs. In his lungs, he had small lesions, but definitively lesions. And you might remember from his past medical history, he was also a smoker. So despite the fact that, of course, due to the large lesions, our first thought was HCC with lung metastasis, we were not really too sure whether he could have a second primary tumor. So the decision was taken that the patient should undergo biopsy. We would have done that anyway because of his non-cirrhotic liver and his normal AFP and no previously known liver disease, despite, of course, having some risk factors. But we decided instead to have actually a biopsy of his lung lesion because we wanted to rule out that he did have a lung cancer in addition to potentially having a liver cancer. And we knew that if the lung would be positive for HCC, there was no doubt that the liver would also be HCC. Now here is what is still recommended from the European Association for the Study of the Liver, the diagnostic algorithm for cirrhotic livers, is that you find the mass in nodular imaging. If it's smaller than 1 centimeter, then you just have repeat imaging by ultrasound, in this case every 4 months. And then if it's stable, you just repeat the ultrasound. If there's a change in growth pattern, which means growth, then you have this patient undergo CT or MRI scanning. If the lesion is more than 1 centimeter in size, then you go right away to either CT or MRI imaging, always contrast enhanced. And if one of these techniques is positive, then it's an HCC. And you don't really need to do biopsy, at least not for diagnostic purposes. But if the imaging is not positive, you could either use the other technique here or go straight also to biopsy if you think this is the better strategy. And then, of course, if you confirm the HCC, you confirm HCC. Now here you see what we did in our patient. We did the biopsy and confirmed the HCC. As I said, we were biopsying his lungs just to confirm that this was a lung metastasis and not a primary lung cancer. And then we decided to remove the bulk of the tumor in his liver so that he would undergo liver resection. It could be done safely because he was a non-cirrhotic patient. Of course, we would not be able to cure his disease because he was already a metastatic condition. And therefore, shortly after resection, we started systemic therapy and probably, well, many would have gone to systemic therapy right away. But if you go for resection, in this case, definitely you need systemic treatment as well. So then here you can see his liver histology. It was HCC low-grade G3 in a non-cirrhotic liver with infiltration of the liver capsule plus the omentum, plus extensive hemangio invasion. You do see here the invasion, microvascular invasion on pathologic imaging, plus also lymphangia invasion here. So a T4 tumor, N0 but M1 with very malignant features here. Indicating that this tumor definitely needs a good systemic treatment if you would have only a small chance of controlling him for some time. So here also, of course, the other reason is to do a biopsy is that not all your lesions are going to be just straight HCC. Even though our radiology is becoming quite good to non-invasively distinguish pure HCC from an HCC, CCC, and then again from small duct and large duct cholangiocarcinoma. However, not always is this pattern so clear as it says here. Arterial phase hyperenhancement, and then here you do have the arterial phase rim enhancement. And an inhomogeneous enhancement, like, for example, the big lesion was seen in our patient, which could also have been a mixed tumor. And then, of course, the tumor microenvironment is different depending on which histologic type you have. And then also, of course, your treatments might especially if you go for immunotherapy, might be more responsive to IO treatment or less responsive to IO treatment. And then, of course, some of the molecular features of these tumors will also help you in the decision to have your patients treated with a TKI or with an IO agent. Here again, it is shown that actually the picture is a little bit more complex than it appears. It's not just HCC, CCC, and mixed tumors, but the mixed tumors can look like HCC, but have a cholangiocyte immunohistochemistry, but you also can look like a CCC, but have a hepatocyte immunohistochemistry. And then, of course, all these tumors behave differently when you treat them. These are the overall figures. HCC is going to be 80% of your liver cancers. There's going to be about around 15% intrahepatic cholangiocarcinomas, and there's about 5% mixed tumors. So basically, if your imaging is not very typical, there is a good chance that you're really looking at a mixed tumor, and if you're not very careful, you're going to miss those, and then you're not going to give your patients optimal treatment. So biopsy actually does give you an additional level of security that you're really getting what you think you're getting. So the situations that mandate biopsy in the guideline-conform way today is, at least for us in Europe, a lesion of any size in a non-cirrhotic liver. And except maybe we could talk about chronic hepatitis B plus advanced fibrosis. This is controversial. I do understand that in an Asian environment where you do have a lot of chronic hepatitis B patients, it might be very reasonable to also accept non-invasive imaging for these patients, to diagnose patients. In our situations where we have very, very few chronic hepatitis B patients, it's not really a big issue, I have to say. Lesions that are not absolutely characteristic for HCC, non-LIRADS 5 lesion, need to be biopsied. If you have a concomitant secondary tumor, second primary tumor, oftentimes you're not really sure whether what you see is actually a metastasis of the other primary tumor, so you might have to do a biopsy to really distinguish between the two. If it's and it's not always very clear from the imaging. Then, of course, if you have a lesion less than 1 centimeter in size, but you still don't want to undergo this cycle of repeat imaging, but you want to have a definitive diagnosis, in that case, you will also have to take a biopsy. And I think this is quite interesting. This is an analysis that was just presented in Estoril at the EASL Liver Cancer Summit by Tim Mayer. And this is the Europe HCC registry. It's a registry of over 500 patients, or it's actually close to 600 patients with advanced HCC treated with atezolizumab and bevacizumab. And you can see Austria and also my site is contributing to this registry. But Tim Mayer was actually showing the data that how the diagnosis was established in this European cohort. And as you can see here, overall histology was taken in 72% of the patient, and it was just 28% that where the diagnosis was simply established by radiology. And you do see some country differences. For example, in Austria, where I live, is over 70% of patients are being diagnosed histologically. In Italy, there seems to be an even higher percentage of patients being diagnosed by histology. I'm not really sure, but it's really possible that it's mandated before patients undergo IO treatment that a biopsy is taken. But also in countries like the UK, over 80% of the patients are actually biopsied. So despite the fact that we have this non-invasive imaging that allows us to establish a diagnosis without taking a biopsy, the reality is that over 70% of patients will actually receive a biopsy in order to establish the diagnosis. So with that, I will close, and I think this will set the stage for some discussions. Thank you very much. Yeah, all right. So I think we don't really have too many questions at the moment in the chat.
Can I ask a question to Professor Marcus?
Of course.
Yes. Thank you first for this very interesting case in Grand Round. I distinctly remember the Kyoto criteria for liver transplant and also the Korean data, and I am happy Dr. Cheng is around. The data said that any non-cirrhotic patient who has a tumor which is more than 8 centimeters behaves as if it is a cirrhotic liver. And the Kyoto criteria also for liver transplant is 10 centimeters. And above 10 centimeters, they would feel, even if it is a normal alpha-fetoprotein or PIVCA, they may have a recurrence. So your patient had 11 centimeters or so. So my question is whether you believe that size in non-cirrhotic does not matter, or what is a size where a large tumor, non-cirrhotic HCC, will be worrisome, number one. Number two, question is, will BCLCC be applicable in a non-cirrhotic liver? Thank you.
Yeah, so we don't really have any size limits here, but of course, this tumor is worrisome, and and as you saw, he had a very malignant histology and malignant behavior. We don't really very often do a primary diagnosis in such a large tumor because most of the time the patient will be under some kind of surveillance, so we will see him a little earlier than that. So this was really a surprise finding because the patient was not under hepatology care, no surveillance, and he was really only concentrating on his cardiovascular disease and his diabetes. I had no great expectations that surgery would make a major impact here on the course of the patient, but in fact he lived, and that was even before the area of IO treatment, definitely before Atezo-Bev. He lived over 2 years with this tumor that was metastasized at the beginning, so it wasn't really too bad. Your second question, whether the BCLC staging system was still applicable for non-cirrhotics, in my opinion, yes. But with regards to the staging, if you mean with regards to the treatment, then of course you can discuss it.
Thank you. Thank you very much. Over to Dr. Moon or Dr. Ghani.
May I ask a question? Do you think that liver biopsy can guide us to whatever targeted therapy that we will use? Because so many targeted therapy right now in the market. Do you think liver biopsy can guide us for this therapy?
So I think at the moment we're still not there yet. We're still accumulating data, and it's not as fast as it could be, simply due to the fact that for many years many centers did not take biopsies. So it makes it more difficult to really analyze retrospectively, at least in a hypothesis generating way,
of potential markers, histologic markers. But I do see when you look at data from IMBRAVE, for example, where there are retrospective histologic analysis, at least you can identify features that will allow you to say this patient will have a better chance of response to IO treatment, and other patients don't have such a good response to IO treatment. And I think as we accumulate more and more data, and this is, I think, what many consortia are trying at the moment, eventually, I hope that we will be able to come up with at least more hints that will help us to select treatment. But today, basically, no. I mean, it's still mostly based on your clinical data, and this is always the strongest argument why we would not do biopsy. You know, and then of course it depends on whether you're an academic institution or not. We are quite biopsy prone, even though we know that for establishing the diagnosis itself, it's maybe not really necessary in many cases. But if you ever want to do such kind of analysis, at least retrospectively, you will need biopsies, because otherwise in 10 years, we will still have the same discussions that we're having today, you know? So, and I guess most academic centers now are moving into that direction, that they're taking more and more biopsies in order to eventually have some data.
Dr. Marcus, can I ask you a question, please? What do you think about combining different modalities of treatment? For example, TACE plus immunotherapy or oral chemotherapy plus TACE?
So, I mean, I think we're all moving towards multimodal treatments. You know, is difficult to study, so it's not easy to generate good data. That's why most of these combination treatment studies either show not a good result or are always heavily discussed if they show a result. But in the end, I think we will we cannot stick with just very, very strict treatment decisions. And that's why we meet at tumor boards, you know, and discuss our patients. And I think everybody, when I look around the world and listen to people presenting their cases, you know, not giving talks on guidelines, but presenting their cases, then what you see is that people actually do these kind of multimodal treatments. Yeah. And this is also what we are pursuing, you know. I mean, in this specific case, it could really be highly debatable whether resecting this patient was of major benefit to him. Yeah, even though I can tell you, at least for his psychological state and his acceptance of further drug treatment, it was very good that we had him operated, because he was much more willing to follow our advice. So, you know, but I think, well, maybe not TACE, but maybe even TACE, but with many other treatments, especially local ablative treatments, also with radiotherapy, that's not part of our algorithms now, but might be a part of the algorithms in the future, because I mean, the data are actually quite convincing, in my opinion. And then combinations also with systemic treatments might be a good option. Yeah. It would be really good, you know, if we would have some very positive data. For example, now when you look at the adjuvant data in the IMbrave 050 trial, it's positive, but it's not super convincing, right? To what you see, but it's good because it will open up the area for other treatments and other options. And in the end, I do think combinations will be done in many cases.
Hi, Marcus. Kadir Dökmeci.
Hi.
Hello. The diagnosis was made more than 90%, especially in Italy and United Kingdom. But in Australia, less than this. Did you satisfy by MR and CT results?
So I think that that just for diagnostic purposes, just to say this patient has a high chance of HCC, it probably would not always have been necessary to perform the biopsy. Because even I doubt that so many patients were non-cirrhotic, because this is just not the European reality. We always have at least 80% cirrhotics in our HCC patients, I don't see so many LIRADS 4 or lower diagnostic images. So I do think that this is something that people also do to get a better understanding, and maybe actually already base their decision on, even though, as I said initially, there are no firm markers where you could base your decision on at the moment.
Thank you.
And in Italy, I personally think in Italy, 90% or over 90% is really excessive. And that might be that the regulatory authorities only give you atezo-bev if you have a histologic confirmation. This is my personal interpretation of this type of data. So this has nothing to do with scientific evidence, but more with regulatory approval.
Thank you.
Okay. We move to the question and answer. There is a question from Kim Phai Pei. Dr. Lau, I hope Professor Jos Lau is still here. Dr. Lau, you presented an interesting patient. What could have been the underlying etiology for your case? What is your take for MSI status for your case? Okay, please, Dr. Lau. Professor Jos Lau.
I don't think he's there.
Oh, okay. So
I think what I saw his case, and I think it's something that it was a very good case, because diagnosis of adenoma is not very easy, and you can really oftentimes not be certain that it's really gonna be an adenoma or a well-differentiated HCC. So I think in his case it was really prudent to go forward with resection of this patient, despite the fact that histology looked a lot like adenoma.
So I can say something as a pathologist for comment about this case. So Dr. Lau's case is very interesting. And then the biopsy showed the beta-catenin mutation. And then the resection did not show beta-catenin mutation. So that's the part, maybe the confusion. I don't know why. Now, generally for hepatic adenoma in young patient, woman is common. And then the hepatocellular adenoma, they have different subtypes also as HCC. For example, HNF1 alpha mutated and beta-catenin mutated, and then inflammatory adenoma and unclassified. These are the major 4 class types. For his case, if beta-catenin mutated, generally they have a higher risk with malignant transformation. Does it matter the size? That tumor should be resected as soon as possible. And then the possibility, for the beta-catenin mutation. So when you do the stins at the pathology, we know the tumor cells, they have a nuclear stain. Normally it's a membrane stain. So for the tumor cells with a nuclear stain, always very scattered, not strong diffuse. So when you see this negative or positive, we need to go to higher power. Try to find 1 or 2 tumor cells with a nuclear positivity. And if you see only 1 or 2 positive, we call that positive. not like other immunostains. If you have 20%, 30%, this one only scattered rare nuclear positivity is beta-catenin mutated. So another way they can do glutamine synthetase. This is another marker immunostaining. So if beta-catenin mutated, strong diffuse glutamine synthesis also confirm this beta-catenin mutated adenoma. So for his case, it's possible still, beta-catenin mutated adenoma. For this adenoma, often with some atypia, can mimic well-differentiated hepatocellular carcinoma. So sometimes small biopsy very hard to differentiate. And also for his case, maybe this hepatocellular carcinoma arising from the background of hepatic adenoma with beta-catenin mutation. Yeah, that's my comment for that case.
Yeah. Thank you, Professor Zhang. Suppose we have a small, say 2 to 3 centimeters nodule with the features of CT scans LIRAP 3 or 4. Should we do the biopsy or just to ablate this lesion? Please, Professor Zhang and also Professor Marcus Peck. What do you
so in my opinion, if you have a LIRADS 4, and you said it's above 1 centimeter.
2 to 3 centimeters, yes.
Yeah.
Yeah.
I would take a biopsy because I would want to know what it is, because if you have an intrahepatic cholangio or at least a mixed tumor, that would have an impact on the kind of treatment that you have. And if you just ablate it, you will never know what you had and what you are getting to. If it's a LIRADS 3, you might as well do a follow-up of this patient as well.
Mm-hmm.
Yeah, from pathologist point, you mentioned for the LIRADS 4, in the background of liver cirrhosis. In this situation, we need to get a biopsy to confirm is this HCC or not. Even non-cirrhotic liver, we also need to get a biopsy because it's not clear based on imaging. It's a benign lesion, hepatocellular adenoma, or foraminal hyperplasia, or HCC, or other lesions. So for the biopsy, most of the time, we will give you a diagnosis. For example, if you think it's FNH, we can call this adenoma. And then you think this adenoma, we may call this FNH. If this really FNH, confirm the pathology. Generally for this patient, you do not need to get resection, you do not need to get any follow-up. So that's very important for get the biopsy. Yeah, I would recommend to get a biopsy.
Okay. Thank you.
And also, for the even for typical morphology, for the radiology, for the intrahepatic cholangiocarcinoma, as Dr. Marcus mentioned, that's why the patient may get liver transplant. And later on, after the explant liver, we review the liver, the tissue is cholangiocarcinoma. That's why many of the cholangiocarcinoma transplantation is by accident. So this may also change the management initially.
Okay. Yeah. Any more questions from the floor? Professor Mamoon, do you have any more questions?
No, I think we don't have any more questions. I think we can hand over the floor to Professor Shivke Sarin to conclude the session. And his concluding remarks, please.
Okay. Thank you very much for all the speakers and also for my colleague, Professor Mamoon. Thank you very much.
Thank you. I would like the comments from Professor Sheena on the cases. He is one of the best experts in the world on liver cancer. So on both cases and the lectures, Professor Sheena, please.
So I enjoyed today's session very much, but so we used to perform biopsy maybe 500 cases of liver tumor biopsy 20 years ago, but at that time, because we thought we are the academic institution and we needed to do biopsies, all the cases. And if that patient has 3 tumors, 3 nodules, we do biopsy from, get biopsies from 3 tumors. And if the patient have recurrent tumor, even we wanted to do biopsy, but nowadays, we perform biopsy only if the radiological feature is not so much characteristic of HCC, or if the patient have non-liver cirrhosis background. In that case, we may perform biopsy. And in your case, Dr. Marcus, we would do biopsy in your case, but in other cases, we don't think to perform biopsy so often. Maybe so in Japan, maybe less than 10% of the tumor will be performed be under biopsy. If the CT and MRI show the typical finding of HCC, we don't think it's necessary. That's my opinion. And maybe in Japan, we perform biopsy only 10% of the cases or like that. So, but I enjoyed, yeah.
I agree,
you.
Professor Shina. And also the problem seeding is very important problem after the biopsy.
Yeah. Yes. And sometimes so even after ablation, we can perform biopsy. And if we get the so specimen, even after the ablation, we can get the correct diagnosis. AT staining showed the characteristic finding of the tumors. So it would work, and it would reduce the risk of seeding, malignant seeding, or like that. So in some cases, we do biopsy after we do ablations. Okay.
Thank you, Dr. Shina. We, in our setup at ILBS, if the patient is non-cirrhotic, we do biopsy generally, and the tumor and non-tumor area. And if it is a patient who is going for immunotherapy, we generally prefer to do a biopsy, although data is limited. But I would like to take opportunity, Ashok, who is the moderator, is the coordinator, for him to coordinate the whole session. Professor Lau, Professor Jang, and Professor Marcus for their excellent presentations on a short notice. And to Professor Sheena, Professor Ghani, Professor Mamoon, and all others for making this a success. We are going to make a difference in all these cases, and the lectures would be available at the APASL website. Thank you all, and we will meet soon sometimes. Okay.
Thank you.
Thank you.
Bye.
Yes,
All right,
thank you.
thank you.
Yeah, thank you.
Bye-bye.
Bye-bye.
Bye-bye. Thank you very much.
Bye-bye. Bye-bye, Professor
Bye.
Shina.
Bye.